trying to pin the high cost of health care on us. We're not going to let them do that.
We are not responsible for the increased costs of these programs, and if the workers wish to continue with them, they're going to have to help us foot the bill.
Payments to health care coverage are made in lieu of wages.
And we're certainly not going to give back anything that we bargained for.
Ray, how you?
In this hotel conference room in Eastwick, Ohio, the first meeting in a highly unusual process is about to take place. Representatives from Mammoth, a large downtown department store, will meet with representatives of the Sales Employees Federation, the union of Mammoth's 800 employees. The last contract at Mammoth was signed after a brief strike, the key issue having been health care concessions demanded by management. Now, after an exchange of letters between the presidents of Mammoth and the union local, a decision has been made to form an ad hoc committee on health care cost containment.
Solve them. Once again, our business and your jobs are at stake.
The step is unprecedented because there is nearly a year left on the current contract. But with a history of trouble over this issue,
last time we gave you back things. We gave you fringes, we gave you...
And with the insurance company demanding a premium increase of 29%, both sides have agreed there is need for extraordinary action.
It's a very serious problem. We really have to get down to hard work.
We have a definite problem. It's a problem.
Management's representatives to this committee include the Director of Labor Relations, Ray Garcia, a former retail clerk himself. Both Controller, Linda Faulkner, and Benefits Administrator, Rick Casey, believe that health care costs can be held down only if the employees share in its cost.
Look at the benefit package in terms of perhaps structuring the incentives.
Jim O'Brien heads the management group. As executive assistant to Mammoth President Bill Riley and the company's troubleshooter, he wants to head off another strike while holding down health care expenditures.
Our costs for health care benefits have doubled in the last 5 years.
Across the table, the union group is led by the local's president, John Beeler, who barely held on to his position after agreeing to the health care cost concessions in the last contract.
We are perfectly willing to discuss this matter, but we want it clearly understood. We don't believe there's any cost containment in shifting cost to the workers.
If you think you're going to wind up getting more money back again, forget it. You know the membership's attitude.
Pat Gray, a seasoned union representative, led the last walkout. He also broke ranks with the rest of the bargaining committee over the final agreement, condemning it as a sellout. A local member for only 6 years, Lana Thompson was a surprise winner in the most recent local election, running on a platform of no more concessions.
And these kind of terms and the terminology that is being used here today to explain and define the plan we have really does not fit within the confines of what the workers are expecting us to do for them in the next contract.
In your eyes, that may be termed restructuring incentives, and in our eyes, that's just plain cost shifting because it causes our members to pay
Meredith Jones, a healthcare specialist from the International Union in Washington, is helping the Eastwick local in these talks, as she has with other locals across the country. The issue on the table, whether labor and management can work together to control skyrocketing healthcare costs.
We're getting bit real hard on the healthcare side, and we want you to sit down with us to recognize this problem.
The positions of both sides emerge quickly.
We've got to ask you to share in taking care of the costs of this healthcare system.
Neither will shoulder the growing burden.
And we are not going to agree to any shifting of costs. We're not going to agree to any reduction of our benefits.
The union demands more information on where the money is going and a face-to-face meeting with the insurer.
Did you do any checking on the insurance man?
We'll
We'd
have
like
to
the
do the
insurance
work.
agent to come in here and tell us so we can ask him.
We need to have access to the utilization and claims and administrative data from the insurance company so that we can look at it ourselves, try to pinpoint where the problems are, and convene again and talk about what we think are the problems in the plan and the types of programs that could address those problems.
Rick, you have any comment on it? There's all kinds of data. I want to spend all day poring over computer printouts. I think the key data
is what Jim outlined in his opening remarks about how much the premiums went up last year and how much they're coming up this year. And it's obvious that we have to do something about that.
But the fact remains, I would hope that if you have any expertise in your job, that you would have at least got some data together other than just tell us it's going up 29%. Now, if you think we're going to convince the membership that they're going to have to pay more or pay anything because your costs are going up 29% because you said so, you're kidding yourselves.
And the information that Meredith is requesting is available information. I'm sure that you don't pay a premium to dedicated insurance company unless they give you substantial information that the premium is necessary. We're only asking you to transfer to us information so that it can be studied and given back to us so that we can help you, as you've asked us to come here to do, come up with a plan that is in the best interest of the workers.
Yeah, these, you know, some of this data are part of our business trade secrets. It's not the type of thing we'd want to see printed and usually misinterpreted by those who don't know how to interpret it in the newspaper next week.
In fairness, you really think that the average hospital stay for our group is going to be helpful to your competitor because he's going to work to get us lower average hospital stay? We're talking about medical facts. We're not talking about facts that get into confidentiality as far as your competition is concerned. If they're secrets, keep them. If you want us to cooperate and try to make this thing work, then let's put all of the stuff on the table, all of the information we can get, and see what we can do with it, see where we can go with it.
Well, I think there are, we can talk about it amongst ourselves when we get out of here, but I'm sure there's some information, useful information, that
management goes along
to resolving this problem that we can share with you.
The teams agreed to return to the table in 3 months. In preparation, the labor and management teams caucus separately. Some insurance company data has been received by both groups, but each team is most concerned with the developments thus far.
Well, we've had our first meeting with the company. Why don't we just share our thoughts? How did you feel about it, Len?
I think clearly the intent of the meeting was to serve notice on us that they intended for our workers to share the cost of their health and welfare plan.
I think we got them on the ropes. I think they know we're not going to buy it. They're running a bluff. They're trying to convince us that they're going to shift the costs on us, and they think we're going to crumble because we gave them some concessions last time. Talking to them may be fine, but I think we ought to make it very clear to them we ain't buying no concessions, and we're not going to start paying them.
I really think we made a big mistake by going with your advice and toning things down. They knocked our brains in that meeting, and that's my feeling anyway. We got to come in with a proposal to these people now when we meet with them. This next meeting, so that when they say, well, what do you have? What's your plan? What do you want? Do we have something concrete that we can lay out? I guess you kick it off, Rick.
We got the plan that we have for our salaried employees. That's
Yeah.
a place to start from. Now, I didn't want to just throw that out there in the very first meeting and say that's what we have to have, but certainly that's a place where you could start talking.
You go in there and you tell them, all right, you're going to pay part of your premium just the way the non-bargaining unit does. And all you did when you went to that and increased the deductibles, you shifted the cost.
I guess after we review what Meredith has studied and presents to us, we'll be in a better position to judge what our alternatives can be to a resolution.
Why don't you give us a rundown, Meredith?
Sure. My basic feeling about the kind of data that they gave us is that it's not sufficient. It doesn't have enough detail. It's not broken down into categories that I commonly use and insurance companies commonly use to analyze data. We don't know certain information like the top 10 most expensive surgical procedures or things like that. So we don't know the frequency with which people have used certain services, and we don't know which services are causing, a problem to be most expensive.
If the company wants to get into a cost containment program, I think they ought to talk to their insurance company before they talk to anybody. These figures seem crazy.
Oh, yeah. It doesn't make sense. There's money that the insurance company has to account for. There's a premium increase that doesn't make sense when you look at the total claims expenditures, which have gone down over the last 3 years, the pattern doesn't make sense.
Have you told them that the data is inadequate?
No, we're going to present that tomorrow.
Well, we're going to have to do that,
Right.
and we will let them know that
Right.
the data is inadequate. Can you think of any reason why they shouldn't give us the data if they have it?
I think that they would like us to have much more of a gray picture, perhaps. I'm not sure of what their motivations are, but I think that they may want to continue the line that our members are great utilizers of healthcare services.
We can sit and we can analyze all this utilization data.
That's what I'm worried
And 2 years down the road, if we make a change for mandatory outpatient surgery or something, you know, we'll find out we saved some money. But that doesn't help us now. We've got to have a fix on our costs.
Where people restructure their benefits and put in some of the upfront deductibles and copays, they can see the savings right away. And you can't do that by, again, you know, studying data over and over again.
If we give them the same plan that the salaried people have, is that where our bottom line is? I mean, do we have any give there? Is this smart bargaining?
What we're talking about is cost shifting right here. And they're going to tell us what the hell to do with it.
Well, we've fallen for their rhetoric, you know, because they call it cost shifting and they call it takeaways. I call it restructuring. Well, maybe that's our rhetoric. But I think the thing to do is to convince them that there is that problem and something has to be done, and this is the type of thing that has to be done. Now, maybe we can structure it differently from the salaried employees plan.
The program's going to work a lot better if there's a financial incentive in it for the workers.
And when they see a payroll deduction and they realize that's coming directly out of their pay, they'll be more concerned the next time they go to the emergency room or wherever.
Damn it, we got to have a coherent program that makes sense and at least has the potential so that we don't sound like we're some bubbling idiots when we go in there.
We need a program that we can convince them with. And I don't think it can just be a program that says, we're going to move some of the costs over to you.
Let's play their little game with them. We'll look at the data, but we're not going to spend months and months looking at it. We'll look at carriers, we'll let them do presentations, and play along with that to show them that we're being cooperative and open-minded, and the data's going to show what the problem is, and the carrier's going to show that changing carrier is not going to change anything, and then we'll put our proposal on the table at that point.
Well, I think Casey and Faulkner both made it very clear in our last meeting that they're talking about cost shifting. They're talking about making us more aware because then we'll pay part of the bill.
Based on the information that you analyze, what do you think is in the best interest of our members?
I don't think that our members are at all responsible for the kinds of problems that are showing up in the data. The way that the plan is designed, and this is something that we'll have to address in our discussion today, the plan has a lot of incentives for our members to use inpatient services versus outpatient services. The coverage is very generous. What ends up showing up in the...
Now you sound like them when you say the coverage is very generous.
Well, I mean that there is no... that basically there's no positive kinds of incentives and there's no monitoring of the use of inpatient versus outpatient services.
And it appears to me that these increases that our workers are faced to kind of underwrite are really not a result of additional claims or additional hospital stays as much as the increase in the cost of the provider. The percentages from one year to another almost align themselves directly with the cost of care increase.
And that's another reason why I don't think management should be so quick to pin it upon our utilization. I think what I'm going to do is give you a quick summary of the kinds of options that are available for healthcare cost containment programs that, as I mentioned before, maintain the level of benefits for our members. As I was talking about, there's the hospital pre-authorization or pre-certification for hospital admissions program. Another program that could be implemented within the plan is to restrict weekend admissions so that people who are scheduled for surgery on Monday aren't checked into the hospital on a Saturday or Sunday. Another program that we didn't talk about but I think is very important are wellness programs. Lastly, I think that we should talk to management about exploring an HMO option, a health maintenance organization option, which is a program that offers care on a prepaid basis. You pay a premium per person, And the emphasis in an HMO is on prevention, and therefore the costs of services at an HMO are much less expensive than they are in a fee-for-service system. And one last point is a new trend in the employee benefits field called preferred provider organizations, or are oftentimes referred to as PPOs. And a preferred provider organization is a network of either doctors or hospitals, it could be and/or hospitals, in which you contract, you negotiate with these providers to offer their services at a discount.
One of the things I'm trying to accomplish by this whole business, and I hope we're all trying to accomplish it, is to get to the point where we do indeed have something to say about how the plan is run. Not just sign the contract and that's it for the next 2 years, and then the company takes over and does whatever they want. If we're involved in the design, then we have an ongoing hands-on involvement with the thing across the year, and not just simply sit down and be told they need a 29% increase, and we're supposed to tuck that away and then come back 2 years from now and hear about a 31% increase.
I agree with you 100%. The more the union is involved in this process, I think the more we represent our membership. When a member...
Mr. Wilson is here.
Oh, okay, thank you. Yes, would you tell him I'll be with him in a few minutes? Sure. Let me interrupt. Harold Wilson's here. You know Harold. I ran into him the other day, and he told me that the electrical workers have just gone through this exact same thing that we're going through in a contract negotiation in terms of cost containment and what they had to do. So I asked him, we knew we were going to be here, so I asked him to drop in and just let us know what happened over there as far as
electric workers here in town with the...
Yeah. Let me get him in. Hi, Harold. How you doing?
Harold Wilson is president of the Eastwick Labor Council. An activist on controlling health care costs, he has encouraged unions to become more involved in this area by learning what they can do to save money at the bargaining table without cutting benefits. Wilson always recommends that trade unionists begin by looking closely at the insurer.
The last couple of years, we've had about 15 or 20 locals in the AFL-CIO jurisdiction of Eastwick area, and you're going the right way. The one plan that was the latest plan that came about was the electrical workers. They had the same problem you had. They was going to escalate the cost on them 25, 30%, or if they didn't buy into that, they were just going to be on strike, and they'd never settle. There's no doubt about it, the company was in trouble in the future. So what they did, they went out and looked, as a union, they went out and looked at other insurance companies to see what they had to offer, and they proposed to management to have the insurance bidded. And they was pretty successful on it. Mutual of Eastwick was the one that was successful bidder, and they've saved a tremendous amount of money. The cost, instead of 32% increase, it only went up 15%.
What was the name of the company?
Mutual of Eastwick. And they're very successful. I think that this is the way in the future. But there's several locals in the area and several internationals working on this. It's a long-range plan. We've got to look at it not only today, but long range. The companies are looking at short range. All they want to do is cost sharing. That's the third program, cost sharing. Let's go short range.
We call it cost shifting, Harold.
I got a letter from Riley, just a memo from Riley, and it's enclosing a letter he got from Beeler.
The labor team is impressed by the savings other unions have been able to achieve by seeking competitive bids. They proceed to invite another insurer to the next joint meeting.
Dear Bill, it has come to our attention that the Mutual of Eastwick Insurance Company has been involved in helping to reduce cost while maintaining benefit levels during other union negotiations in the area. I have invited a representative. It's to our meeting, he's inviting a representative. I have invited a representative of Mutual of Eastwick to join us at our November 14th meeting. Lou Nelson has been recommended as the man at Mutual we should talk to. Thanks. Sincerely, John Beeler. Well, I don't know. I like the fact that he's thinking the same way as us, but I damn sure don't like the fact that he's almost dictating to us.
What's he got, a brother-in-law who's a sales agent for them, marketing agent?
Mutual? You ever heard of Mutual?
Well, one of the problems is going to be that we're almost losing control over meetings that we called.
The second joint meeting opens amidst an atmosphere of suspicion. Representatives of the current insurer have come to defend the proposed increase, claiming, as does management, that union members have overutilized the plan.
That 29% increase has got us flabbergasted. We're trying to work out something here with the union. You know, we want you to know we've had a good, solid relationship, but nothing lasts forever. You got to prove to us that we're getting the goodbye here, because you know, it's either we're getting the goodbye or it's goodbye.
First, let me say that it's really my pleasure to come here and talk with you and the management team and your workers. It is a tough situation out there today. Hospitalization costs are going up dramatically, and you only get what you pay for, and you have a Cadillac plan. You can't have your cake and eat it too. If you want us to pay all of these benefits quick as we can, unlimited checkbook, it's going to cost. And that's what you're seeing. That's the result of it.
Now, if I may just take a second and try to explain what we see as some of the problems as borne out by the data. Now, the data, as you know, in the last 2 years, we have put in a very sophisticated data analysis system, part at your request.
You got all this sophisticated data. Why haven't we gotten it?
Oh,
Yeah, we
I
have
think
a
we
serious
did,
problem
I think we
with
did present Mammoth Stores with some data.
And we shared it with you.
Yeah, well, this is hogwash.
I'd like to point out, Mr. Brown, that data that you've been proud of is data that we found grossly inadequate. Normally, when we get utilization data, the breakdown is at least in diagnostic categories, and it would include number of cases, days, charges, average length of stay, and average payment.
You know, you're asking for an awful lot of detailed data that I don't even know what you would do with.
What we're going to do with that is actually develop a cost containment program that addresses those specific problems, so that we're not designing a program that's general, that may not be hitting the sources and the problems that are in our particular plan.
We want more too. We want more information. And but what we have is, we think, is not just a drop in the bucket. There is significant information here.
Well, let me ask you if you would even entertain, considering that all employees of Mammoth is involved in this health care program, would you entertain paying a 29% increase when you don't know absolutely where the last increase was spent?
We won't entertain paying a 29% increase.
Period.
Period.
I'm wondering if we can get to what you guys would recommend. Now, obviously, you have proposed a 29% increase. That's totally unacceptable to both sides of this table. But you're the experts in the field running these programs. I'm wondering if you could tell us what we might be able to do other than the 29%.
Well, yeah, I think our recommendation would be specifically what we said to you about your management plan. These services are being overutilized by the plan participants, the employees. You know, there's a lot of data to indicate that. The RAND study has proven conclusively that by adding a little...
I'll tell you what you can do
You
with
know,
that
you people
RAND
are very
study.
rude.
Yes, you got that right.
All right. All you're offering yourself is a bank. You take the money in and you pay the money out.
No.
You don't do anything to screen what you're taking in. You don't do anything to screen what you're paying out.
You know, this is not the first time we've faced these problems with companies. It's difficult. But the problem, quite simply, cutting away all of this crap about give me data, give me that, give me the other, the plan is being overutilized.
Tell us,
Well,
Roy. Trust
it's
me.
not crap. Every single thing we've asked you for is of value to ourselves and to the company. And I resent very much you referring to it as crap.
You wanted our recommendation?
That's not the way it's working. Okay, well, thanks a lot, Roy.
Yeah.
Let's
Okay,
go.
thank
We've
you.
got a lot of
Thank
business
you.
to do. Bart, you too.
Thank you.
We'll see you. Be good. I'll be in touch.
Take care.
Okay?
Good job.
Thank you.
Thank you.
Good job.
We're rude and tells us what we want.
Yeah.
Recommends the plan.
It's going to be something.
What the heck kind of a person is that to deal with? You wouldn't buy stuff to sell in the store from a vendor like that. This first thing you might want to do is
Well,
Look elsewhere.
we're willing to do it. We're willing to look elsewhere. I'm not so sure that we're going to find a golden solution if we look elsewhere, but we're damn sure willing to do it. How's about a proposal from you?
Let's bring this fellow in. We asked to come here. We're not sponsoring him. I don't want that misunderstood. But let's hear what he has to say. Lou, how are you? Good to see you.
John, good to meet you.
Lou, seriously, on behalf of management, we welcome you here.
Thank
And
you.
I think we need to be educated, and any information you can give us, we'd like to hear from you.
I'm here to sell you some insurance, okay? We think that we can be competitive, and we think we've got some programs, we think we've got some experience working with labor and management to help make consumers wiser medical shoppers. Are you familiar with mandatory second surgical opinions and pre-admission certification? Is
We've
that
had a
something
little
that you've been
discussion about
involved
it.
with?
We've just begun to become familiar.
Okay.
We are more than open to learning.
You're probably spending about 45 to 50% of your healthcare dollar on hospitalization. And probably 60% of that is devoted to surgery. So it stands to reason, if we can avoid hospitalization, if you can avoid unnecessary surgery without compromising quality of care, then you're going to save big bucks. The way our proposed second opinion program would work is if we would supply you with a list of surgical procedures, elective, non-emergency surgical procedures. We've got about 30 procedures on that list right now. The employee would then be given the name of a physician. You would then go to that physician. Mutual of Eastwick would pick up 100% of the cost for seeing that physician.
Our employees now can get a second opinion. It's a voluntary basis. They can go, and perhaps we ought to get some data and try to look at it, but I don't want to be the one, or let me just do it for a change, defend the employees a bit. I'm skeptical of making them have to go and get a second opinion.
Can we get this verbatim? You're going to defend the employees?
Sure, I'm trying to help you out.
Well, I'm not...
Whatever the issue, we're talking about potential savings maybe. We aren't talking about...
Excuse me, go ahead.
We aren't talking about what we need. What we need is an immediate saving.
One of the things that I think you need is to keep people out of the hospital and out of surgery who don't need surgery.
Right.
Our experience tells us that mandatory second opinions are the only way to force that issue. The problem is that we get conditioned to listen to the docs. The doctor says this and you do it, and you're afraid of offending him. If you weigh the alternatives, which are a 29% increase, is that what you said?
Yeah.
Or a real shot at keeping those costs down, they may go with that.
You've given us this presentation. Why don't you let us mull it over hard copy, and we can get back to you with any...
And again, we want your business. If there's any way that we can help you get a meeting of the minds on this, please call me.
Okay, we certainly will. We'll stay in touch.
I hear you. I hear
great.
you. We'll be in touch.
Thank you.
Thanks a lot, John. I appreciate you bringing them in here.
Thanks, John.
Bye. Bye.
Bye, Lou.
I wonder if you want to sum up for us where we might go and what we're doing.
Well, I'd like to say that Mr. Nelson's presentation touched upon two programs I think we ought to think about a lot more seriously. These are programs that can get at the areas, the problem areas that we've both identified in the plan. Mr. Nelson talked about a hospital pre-certification program, which our international has had a lot of experience with. These are the kinds of...
You're talking about things that cost more money? Or?
No, this whole overall plan that we're looking at, the kinds of plans that involve the hospital pre-admission program, that build in the second surgical opinion program, that look at outpatient, that focus on outpatient use of services. These are programs that have been proven to be cost-effective, can save the fund money without hurting and cutting back on the benefits of our members.
How are you going to do it, Ms. Jones?
How do you guarantee it? How do you guarantee we're going to get that savings? You cannot pay that 29% increase.
I agree with you.
Somebody else has got to pay it, but these are very
long-range
long-range
to pay the
things.
29%.
But
John, the last time you people complained, and I I have to admit with some justification that we didn't present you with a specific program. We've got, I asked Rick to come up with some figures. So Rick, why don't you take it from here, okay?
Okay. We want to ask the employees to begin paying 10% of the premium and by payroll deduction, and we want to increase the individual deductible from $100.
Just go step by step, please. Go ahead.
The $100 deductible for an individual will be raised to $200. And the $200 family deductible will be raised to $400.
Does this deductible apply to the same services it
Yes,
did before?
same services as now. We're just raising it. Now, we had Aetna cost this out and apply it to our represented employees, and it will save over 3 years in the ballpark of about $4 million.
We started off in our very first discussions saying that we were willing to discuss how we can bring some relief to this situation. We're anxious to do that because it means our money as well as your money, but we also said no cost shifting or no cost sharing. This obviously is cost sharing, both in the deductible and the premium. In terms of your proposal number 1, the answer is no. In terms of the proposal number 2, the answer is no. In terms of the proposal number 3, the answer is no.
Hi, I'm Karen Ignani, Healthcare Policy Specialist for the AFL-CIO. This is Roy Dickinson. Contrary to the intransigent insurance representative you play in our film, you are in fact a very successful healthcare cost buster for the IBEW. Meredith Miller with SEIU. Meredith, I guess you're the only person in the film that's playing yourself, because you do indeed play the role that you played in the film in real life by going around servicing your local unions for SEIU. It seemed to me that there were 3 issues that we really dealt with in the film: the question of process, the question of data, and then this business of what can unions do. Let's zero in on the process question for a moment and really discuss the pros and cons of working together with management outside of the collective bargaining situation like they did in the film. Roy, what do you think about that?
I think it's very important. 2 reasons. If you wait until the time you come to bargain the entire contract, there's not enough time to address all of the issues in healthcare cost containment. The second thing that happens is management has had time to think about the cost problem they're facing, and they've come to a solution. Their solution is very simple. We're going to make the union members pay more for the plan, and we won't have to worry about it. And you don't have real time to deal with that issue in the time frame of actual negotiations for a contract.
So you think it can work to our advantage?
It has to, yes.
Meredith, what do you think about that?
I think I agree with Roy entirely that when you do this more and more in advance, trying to meet with management about healthcare costs, it really gives the union an opportunity to get data that we're now realizing takes a long time to get. And so getting data, finding out where management's coming from, it really helps by starting early.
But I'm sure there's some reluctance on the part of some of your members. We saw the Pat Gray character, sort of the standoffishness, and in fact sometimes apparent hostility about participating with management in a session that's fairly extraneous to bargaining.
You think you're going to wind up getting more money back again, forget it. You know the membership's attitude.
Why do we need data, first of all?
Well, we need data because we need to be able to analyze why healthcare plan costs are increasing, if they are increasing. For us, it allows us to make an informed decision about what's going on with the plan. It gives us ammunition to deal with management's proposals for cost shifting in the plans. And it also is important to be able to educate our members.
Are we entitled to it, Roy?
Oh, absolutely. We're entitled to it. Basically, under the National Labor Relations Act, we're entitled to all the information to intelligently bargain the contract. and healthcare data is necessary information. It's a mandatory subject of collective bargaining.
Do you find that at the bargaining table, that there's a real reluctance to share data on the part of management?
Oh yes, I have yet been in a situation in collective bargaining where data has been readily handed over by management, and we have had to state clearly that kind of data is, if it's associated with healthcare bargaining, healthcare is a mandatory subject of bargaining, and therefore we're entitled to that data, and we don't want to have to file an unfair labor practice to get it, but that is one possible resort. So it always has been a difficult thing to get from management.
What kind of data do we ask for?
Again, you've got to look at the time frame you're asking for it. If you're in the middle of negotiations and you get a pile of utilization data, how many people had appendectomies per 1,000 and how many people had a heart attack and how many people had this, that, or the other, what the costs were, the average cost, you really can't analyze that data.
You might need a hospital stay to figure it out.
Yeah, that's about it. That's part of the advantage of starting early. You take the data, you can analyze it, and you can develop your program from that. Types of data, certainly you want to know the utilization. You want to know how many surgeries of various types per 1,000 there were, and you want to have a national norm to compare it to see where your group is out of sync with the national norm. There may be too many hysterectomies per 1,000, or too many appendectomies, or tonsillectomies, or open heart surgeries.
And so that brings up this business of utilization. We heard a lot about so-called overutilization in the film. Roy, you were very good about passing the buck, talking about this so-called Cadillac plan that labor had and that we were responsible for rising costs.
These services are being overutilized by the plan participants, the employees. You know, there's a lot of data to indicate that. The RAND study has proven conclusively that.
We hear that an awful lot at the bargaining table. What's the answer?
Well, the answer is quite simply, who controls the utilization? And the person that controls the utilization is the doctor. The doctor tells you, you go to the hospital, the doctor tells you you need surgery, the doctor tells you you need tests. The doctor is the controlling factor in all of the healthcare costs.
Now, Meredith, you made that point really very clearly in the film, but what about this RAND report? I'm sure you're confronted with this every time you leave Washington and go to a local bargaining situation. What do you say? Pat Gray probably had the best response on what you do with the RAND report, but be that as it may, what do we say?
Well, the RAND report is a report that management uses to try to justify cost shifting. The RAND report is not reflective of the kinds of plans that our members usually have, and therefore the conclusions of the report can't be applied to our situation. The RAND report is very controversial. There are even RAND researchers who don't agree with that report.
I think the RAND report, you have a number of things to look at. What most employers say, the conclusion of the RAND report is if you raise the cost, people won't use it as much because they've got to pay and they think. That's not really true. That plan showed that adding additional costs really didn't impact utilization. That the doctor is the one that controlled the utilization when you went to the hospital. And that was true consistently through the RAND report.
Does that work for you at the bargaining table when you get into the details? Get past this business of labor being the person who's to blame?
Yes, I think that it really has helped us to try to show that people are not to blame for the health care costs, and that they're not the people who are in control, and that 70% of every hospital stay claim is definitely due directly to decisions that doctor makes, not what our members are making.
That brings up another point about this business of competitive bidding. It was clearly brought up when Lou Nelson, the other insurer, was brought to the table, who painted a very different picture than the picture you painted to the labor team.
I'm here to sell you some insurance, okay? We think that we can be competitive, and we think we've got some programs, we think we've got some experience working with labor and management to help make consumers wiser medical shoppers.
Have you folks found that this business of competitive bidding can work or can give you a strategic advantage?
Oh, I think that it's been a definite success with our locals. They may really do a much better job for you,
So
and you may find a better product.
Even someone like Roy would change his tune when there's a competitor waiting in the wings.
Little competitive force never hurt anyone. But But yeah, there are a couple of things you need to be careful of in that too. A lot of times you will find some insurance companies that'll come in and give you a low ball for the first year, thinking the second and third year they can make it up by really increasing the premium. So you've got to be careful of that.
I think from the film we really got the idea that we don't want them just to compete on premium, but we want them to compete on service, which really gets to the heart of what you were doing in the film. And I suppose the question that comes to mind is, are these things like pre-certification, mandatory second surgical opinion that we covered in the first film and we're really going to see unravel in depth in the second film, are they worth something to us at the bargaining table? In answer to the comptroller's charge that we've got to save that 29%.
How do you guarantee we're going to have savings? You cannot pay that 29% increase.
I agree with you.
Somebody else has got to pay it, but these are very long-range things.
29%.
Do we get something from doing these things?
Oh, sure. I was just at actually a competitive bidding session yesterday, and two of the carriers who are major insurance carriers in this country were offering upfront premium discounts ranging from 3 to 5% for a hospital pre-certification program that included second opinions.
So we don't have to wait 2 years down the road?
No, actually the thing about these programs is the minute you put them in, they work. They work the day they begin. Every time one hospital inpatient stay is switched to an outpatient basis, you save money. It doesn't take a year or 6 months. Savings begin the minute the program starts.
And the key is, as Roy said, you begin to change provider practice patterns, which is the secret of this overutilization business.
The other thing you need too is very good record keeping and accountability on how these systems are working. You need to know if you're using a second surgical opinion, how many were performed, how many people didn't have the surgery, and track that long term.
And trade unionists have to be willing to do that.
It's time-consuming and it's tedious, and yeah, amongst the 100,000 other things we're telling our leadership people that they have to do, this is one of the things.
Well, we ended on a very high or low note, depending upon your perspective. No, no, no. I'm looking forward to seeing how these issues are going to be resolved in the second film.